So winter is coming. Actually, winter's here already. And with it, we get our high volumes of all emergency departments, but especially the pediatric emergency department. It's all the respiratory viral illnesses, all the bronchiolitis begins to flood our gates. And we end up with long wait times, crowded emergency rooms, and it enters into kind of a hazard situation of wanting to make sure that nothing is going wrong in the waiting room and in the triage bay as we try to safely go through all of our patients. And every center wrestles with how to do this safely and more efficiently. One of the common models is to put a physician into triage to try to pre-order things for patients. Let's get that x-ray going for the kid with the fall and the swollen wrist so that the team that takes them on, when they make it into the main body of the ED, already has good info to work with. So as we do that here at our site as SickKids, one of the things that's been happening when the point of care ultrasound team members are working out of triage is we really begin to get this sense of how we can tailor downstream care the sooner we involve point of care ultrasound in the care of children coming to RER. We've had a lot of these respiratory kids where we diagnose a pneumonia and they show up with a history of asthma, with some wheeze and maybe mild fever, and instead of that multiple hour wait it would take to get seen by a physician who would then go and debate using bronchodilators and maybe send them for an x-ray or maybe not, depending on how things go, we find their consolidation in triage. And they often don't even make it into the main body of the ED because we have a safe and appropriate treatment plan in place. And during the same time, I've had the experience of diagnosing things that I was surprised to find as early as I was finding, and that worried me about how long they might otherwise have waited in the ER. We're talking about cases of ovarian torsion that we diagnosed in the triage bay, cases of appendicitis with a lot of secondary changes making you wonder about perforation and whether that patient needed to be on antibiotics. So imagine going into a triage bay and telling all of the nurses working there that we needed to take away their stethoscopes. This is kind of the feeling that I was getting working in triage with ultrasound, was how could we then take this tool that was proving so effective away from that environment where it may have the greatest impact? And this is really one of those things that as machines miniaturize and as they become less expensive and we look to the future, that we can only imagine that training nurses, training our frontline providers at the first point of contact with patients in point of care ultrasound, if we do it right, if we get them accurate, we're only going to increase efficiency and improve safety for our patients.